to invite Professor Boris MALYUGIN from Russia, Moscow, to give this very important keynote address of the whole morning session. So, Boris, thank you once again for coming here and sharing your knowledge.
Thank you very much, Abai. It's my pleasure to be here with you today and share some of our latest research on the role of anterior vitreous detachment for cataract surgery complications. So we do remember the lens capsule anatomy, and we know that the thinnest portion of the capsule is in the posterior segment, and it's 4 microns. We also know that the anatomy of the posterior surface of the lens and its interrelation to the anterior surface of the vitreous body is quite complex. There are several channels like PT canal, and there is a vigor ligament that is attaching the vitreous to the posterior capsule, and it's shown here by scanning electronic microscopy, so that there is a quite firm attachment in between the posterior capsule and the anterior hyaloid membrane, and also zonules are involved in that attachment. And we know that from John Wurst that the anatomy of the vitreous body is also quite complex. In spite of this transparency of this tissue, the VITREO-LENTICULAR interface is having several characteristics. It's very transparent. It's having a low number of cells, completely avascular. It has a distinct consistency forming the anterior hyaloid membrane, and it has peculiar biomechanical properties. So this is definitely a very interesting anatomical structure. And first it was described related to the posterior curvilinear CAPSULORHEXIS that was first introduced into the clinical practice by the Belgian ophthalmologist Albert Galland. And then more recently there was an interest in that structure that was also generated by Belgian excellent surgeon Marie-Josée Tassignon. She was studying the relationship of the posterior capsule and anterior vitreous in congenital cataracts. And it was shown that there is a complex relationship, and there is a dysgenesis of the Berger space in patients having congenital cataracts, which was later on proved by immunohistochemical evaluation, studying the interrelationship of these structures. Actually, in our clinical practice, we were being able to study the anatomy of this structure by intraoperative OCT, which is we do have several systems now available for the surgeons, and I'm using one of them showed here. So intraoperative OCT does not give you the opportunity to study the interrelationship between posterior capsule and the anterior vitreous before the surgery. However, during the course of the procedure, you can actually see when the lens is implanted, and you see the lens is implanted into the capsular bag, and this is a very typical appearance of the posterior capsule, which is having a wavy shape. And also in some patients we can actually visualize not only the posterior capsule but also the Berger space, which is the space in between the posterior capsule of the lens and anterior hyaloid membrane. We were quite interested in that space because in some of the patients we've seen the particles that are located behind the posterior capsule, and they were actually located behind the lens, and we were not sure where is these particles are located. So we were trying to use intraoperative OCT in order to find out the exact location of these fragments, and as shown here, sometimes we were being able to identify them on the OCT as hyperreflective dots located somewhere behind the posterior capsule, and again you see these dots here. So this is another representation of these particles. You see this these dots that are located behind the posterior capsule and in the anterior portions of the vitreous. So this is what we actually can see postoperatively. We also can identify these mini fragments of the lens. However, this exact location is not really obvious in this case. So we studied a number of patients preoperatively and intraoperatively and postoperatively, and this is the summary of results. And we've seen that in 71% of patients, we actually were being able to identify the Berger space, and we've seen in some of these cases hyperreflective membranes, hyperreflective dots located behind the posterior capsule. However, it was not always being possible to identify that in postoperative OCT, as shown here by the difference chart. So let's have a look what's going on during the cataract surgery. So we see that there is a posterior, the detachment of the posterior capsule from the anterior vitreous hyaloid membrane, and there are several predisposing factors to that that may be age-related, comorbidity-related, and also surgically related by fluid passing through the zonules. So this is a kind of mechanism that happens. So the fluid goes through the zonules, goes behind the posterior capsule, and leaves the capsule above the regular plane. This is how that happens during the surgery. And again, when we are fragmenting the lens are going, these lens particles are going through the zonules and accumulates in the area in front of the anterior hyaloid membrane. Again, you see these particles here, and as shown on that video fragments. However, as I mentioned to you, it still was not absolutely clear where these particles were located, so we tried to prove the concept by injecting triamcinolone acetonide through transzonular injection is now being done, and excessive substance was removed from and washed out from the anterior chamber, and then we observed these hyperreflective dots in this area in between the posterior capsule and the anterior hyaloid membrane, proving that this is exact location of these particles in that Berger space. So what's happening with this condition? So when the fluid goes behind the posterior capsule, it becomes flat, and then it's easy to be aspirated by the irrigation aspiration handpiece, or it can be in the contact with the ultrasonic vibrating needle, making that complication to happen. So this is how that happens, and this is how PC rupture occurs during the course of cataract surgery. Again, we see inflation of the Berger space. flattening of the capsule from the oblate to having a prolate shape, and then aspirating the capsule. This is a clinical example. We see this is the patient with the posterior capsule, which is not oblate. It is rather prolate and locating in the plane of the iris. That makes the aspiration much more, chance of aspiration much higher. So this is how that happened during that surgery. During cortical cleanup, the capsule was aspirated, and of course we need to avoid anterior prolapse of the vitreous, and we can actually see this hole in the posterior capsule, and sometimes even vitreous herniation can be observed on anterior segment OCT, because vitreous goes out and prolapses through that hole. By injecting viscoelastic, it's possible to reposition the vitreous, make the posterior CAPSULORHEXIS, and as shown here, reposition the anterior hyaloid, and then implant the IOL, and again you see the IOL is located in the capsular bag in that case. So this is just another clinical example of the vitreous and the posterior capsule damage during the last steps of the phacoemulsification procedure. And the reason for that, again, is that a fluid that goes behind the posterior capsule, lifting the capsule and placing the capsule in contact with the vibrating ultrasound needle. As shown here, this was the contact in between the needle and the posterior capsule, and definitely we need to convert that into the posterior curvilinear CAPSULORHEXIS and to be able to evacuate the cortical material and implant the IOL into the capsular bag. So to conclude, we do think that intraoperative OCT verification of crystalline lens particles or medical suspension in the space between the posterior capsule and the anterior hyaloid membranes confirms the inconsistency of attachment of the vigorous ligament in approximately 70% of cases, and this defect of vigorous ligament could be a source of capsular complications due to excessive hydration of the retro-lenticular space. And we published this in this year in first number of GSCRS. This is our article on the results of that study, and we even come up with a classification of the of that syndrome, starting from first grade, when we cannot see any lifting of the posterior capsule, and going to the third grade when the prolapse is more or less significant. And I thank you very much for your kind attention.
Thank you, Boris, so very much for enlightening us for relatively a new subject or new area of interest, which has a tremendous impact on the patient's health when we perform any surgery, particularly cataract surgery and so on. So thank you so very much. I think, thank you, and I just want to say finally that the cataract refractive surgery has become a norm, and patients expect that. So keep all the options open for the patients, counsel them well, assess them well, and then patients will be very happy, and you will be also very happy. So thank you so very much for your patience and patient hearing. Thank you.